I got noon on my watch, so we are going to get going. I am Dusty, one of the co-founders of Cowork Health. I got with us today the one and only Dr. John Kaler. I will introduce him and then we will get started. Dr. Kaler, he has been in the space for over 40 years now. He started a group of clinics called Physicians Immediate Care, grew that to 56 clinics. It was a blended, urgent care Occ Med model. In his time there, though, they grew it to over 10,000 Occ Med clients, which is pretty awesome. He also helped found, was one of the founding board members of Urgent Care Association and has since started a company called Occ One, which helps clinics provide their providers with resources to make sure they can serve and service all the necessary procedures in clinic rather than sending those out. On our side, Cowork Health, we are essentially a Occ Med portal and platform to help organize your Occ Med relationships. So that communication piece, invoicing piece, resulting, all that good stuff. That's what we're doing on our side. So let me share my screen here and I will hand it over to John. If that weren't enough, Dr. Kaler is also working remotely today because he is celebrating his 16th grandchild, which is pretty awesome. But other than that, he's got nothing going on. So, Dr. Kaler, I'll hand it over to you and you can get going.
Okay, great. Thanks so much, Dusty. Appreciate it. So I like this topic. I really want to talk about this topic because provider performance is utterly critical. It is the single most important feature and factor of your Occ Med program, whether you're a blended model or a pure Occ Med clinic group. Provider performance is number one. Okay. But first, I want to talk a little about what's going on in national trends, always of interest to people. We are in a crisis of profitability right now, which is going to create sustainability issues and has already done that. Large, well-known brand name groups like FastMed, MedExpress, NextCare, they're in basically slow liquidation. They're selling off their clinic network state by state. And looks like the number one buyers of those seem to be more like health systems, which are I'm not criticizing anybody, but a little less profitability sensitive. In other words, they're very much more interested in the catchment zone, the referrals to the health system, kind of that kind of thing, building their own ecosystem and having urgent care as part of it. Whereas independent groups are standing alone. They can't use OR stuff and ER stuff and imaging as part of their profitability equation for an urgent care center. So we're seeing tremendous challenges with profitability out there. I know that because I have visibility with the folks I work with Occ One and others, that there is profitability challenges right now. The issue is multifactorial. It's not just one thing, but provider performance on injury management, workers' comp is a contributory factor. That is, when provider performance falls on injury management, so does profitability. Okay, so profitability equation, it's illnesses and injuries. That was our business proposition to the healthcare ecosystem originally, because I was there near the beginning of this industry, was illnesses and injuries. And websites have always had fractures, dislocations, all these lacerations on their website, but they're not, a lot of these urgent cares are not treating them anymore. They're just triaging them. Okay. That's a huge word differential, treating versus triaging. So triaging is not treating, and healthcare payers out there have noticed the degradation of acuity in injury management. They're responding accordingly, trying to offer ridiculous case rate contracts of $75. And for triage, I mean, I guess so, but why not treat them and make 500 to 1,000 on these cases? But anyway, crisis of profitability. It's linked in some ways to injury management, workers' comp, not doing Occ Med, other issues like wage inflation is a big issue, rad tech shortages, that's a big issue, and coding and billing, but that's a bit different. But anyway, so there, within every crisis, there is an opportunity. Okay, the Chinese character for crisis is also opportunity. Okay, so where there's a crisis, there's an opportunity. So I can tell you, after all these years, there has never been ever, not even close, a better time to do workers' comp injury treatment and management than now, than right now. And it's getting better every week. Okay. And that is because urgent cares nationwide absolutely unequivocally are dropping the ball on workers' comp. Okay, so let's go to the next slide. So we want to grow your Occ Med business. You have to have customer satisfaction and retention. Okay, there's so many groups out there. They go, oh, we have an Occ Med program, and you kind of ask them some questions. You realize, yeah, they do occupational medicine. They'll do some drug tests. They'll do some workers' comp, but it's actually a revolving door. They're gaining them and losing them, gaining them and losing them. They're not really truly frame shifting their practice up with each ongoing month where they're adding customers and not losing customers. So, I always said, I went to a conference once. It was actually an Occ Med conference, and one of the talks was Occ Med sales. And one of the speakers said, um, well, you really have to do Occ Med sales because eventually you're going to lose every client you have. So you have to replace them. And I'm sitting in my chair and I go, whoa, that's not going to happen with me. I said, no way. Okay. When I get a client, they're hard enough to get to begin with. When I get a client, I'm not going to lose them, so that I'm always adding to my customer base in Occ Med. And obviously, what Dusty mentioned, we made it to 10,000 clients. And so I do understand, I do know how clients think in workers' comp. And so let's go right to the kind of the elephant in the room on this talk. And I'm going to make it, it's going to be so simple. It's literally practically magical that the number one determinant of Occ Med success is provider performance. The number one determinant of provider performance is this, okay, is the big four. The providers must avoid unnecessary lost time. Like, don't take people off work when they don't need to be, okay? Avoid unnecessary OSHA recordables. Your work restrictions must be intuitive and make sense for the job the worker does. Fourthly, they need to call the company on the first comp visit. The provider that sees the patient on the first visit on the work comp injury needs to call the company contact person or designated employer representative for workers' comp and just share, real quick about the case. Like, I saw Joe today. He's got a lumbar strain. His x-ray is negative. We're going to give him a back support, Tylenol, naproxen, non-recordable. He'll be on a 30-pound lifting restriction. I'll see him on Tuesday. Done. Boom. How hard is that? That was 10 seconds. Okay. Yet it's one of the big four. Now, notice in the big four that if your providers will do those, and none of that I just said is putting a shoulder back in or sewing a tendon. Okay. Those administrative. Those are administrative issues that you, with the stroke of your pen and with a phone call, you've done that. If you do that, I'm promising you that your sales impact will be dramatic. Why? Because you'll gain clients by word of mouth. I'm dead serious. Okay. You can have a sales team, and you should, but you'll be getting incoming calls saying, hey, I heard you guys are great. Can we talk? And you'll go over there and land the account. Why? Because you're doing the big four. If your providers are doing the big four, day in, day out, consistent, and this means all the providers, not a few of them, not the leadership, or the quote unquote Occ Med specialist, PA or physician or what have you. No, all of it, 100%, because they want consistency on the big four. So I just told you a trade secret. There's a massive trade secret, what I just told you. Okay, so sales impact, customer satisfaction, you will retain them if you do the big four. I'm promising you that. Okay, next slide. So provider engagement. So for providers to perform on the big four issues I just mentioned, they need to be engaged mentally. Okay, so if they have kind of the urgent care engagement mentality, which is very much illness oriented, amoxicillin, Z-Paks, all that, right? That's they're engaged with that. That's their paradigm, and they understand it, and they're very comfortable with that. But provider engagement on workers' comp is different. They have to accept a different way of thinking, like not taking people off work. Well, why'd you take them off work? Because that's what I always do. I take people off work when they have an injury. Well, what's the medical reason why you couldn't put them back to work with restriction? The answer is, I don't know. Okay, why? Because they're not engaged. Their brain has not been engaged with the paradigm of workers' comp, which are the big four. So the culture of the company is really important. What is that culture? Is this a culture, a can-do culture, a rock and roll culture? I want to do this more. I want to practice the highest level of my license. I want to do procedures. I'm aggressive. Or is it kind of like, don't bother me. I just want to give out antibiotics and get paid. I mean, and that's an extreme, other side of the coin there, but there is the spectrum, okay? Is like, I'm not, you're not paying me to do workers' comp. Well, yes, we are, because that's what urgent cares do. You know what I mean? So it's crazy the things that are being said by providers about workers' comp. So when you're hiring somebody, you really need to figure out, will they fit in your culture or not? Are they a can do person? Do they appear to be energetic, or do they appear to be, you know, moribund? Okay. Okay, which is not good. All right, so in your hiring process, have you sewed lacerations? Have you done some fracture care? Are you comfortable with procedures? Are you willing to do soft tissue injections? And you'll get an idea. They might say, well, I really haven't, but I'd be excited to learn how to do that. Well, that's good. That's high energy. That's the kind of culture you want. Or, well, I'm really uncomfortable with that. I don't know, maybe you can teach me, if they're, that's an issue, that's a concern. All right. And then how are you going to support these providers so that when they're engaged in workers' comp, make sure they have support where they can make a phone call and get back up if they feel like they're uncomfortable with something. And I'll be reiterating that a little bit later. Next slide. Okay, so performance drivers, these are some things that are inherent in the individual, and some require them to kind of get out of their comfort zone, so to speak. So personal motivation, I already mentioned that. Are they personally motivated to do more, to practice at the highest level of their license? And then leadership dynamics. This is really important because everybody puts their finger up in the air and figure out, which way is the wind blowing about this company that I work for as an urgent care provider. Are the leaders kind of like, just status quo, maintain the status quo, kind of like, make sure you show up for your shift, finish your charts, that kind of thing? Or is it, hey, let's up our game here. Let's do some training, let's do some workshops. Let's do some pig's feet suturing. Let's do some soft tissue injections with pig's feet or with a mannequin. Let's learn how to treat eye injuries with hard-boiled eggs, taking the foreign body off the hard-boiled egg, the same as like taking it off the cornea and those kind of things. So is the leadership dynamics high energy? Okay. Is the leadership, the medical leaders of your clinic themselves, are they can do, high level, want to do more, want to make sure everybody practices at a high level like them? Are they setting a good example? Are they themselves referring things out? Are they themselves taking people off work unnecessarily, OSHA recordables, all that? So your medical leadership, all your providers will note what is the posture of your medical leadership. You've got to make sure that they're engaged themselves. And if they're not, if they're a physician executive, chief medical officer at your group, and they're not engaged, you need to look elsewhere. You need to, you need to make a change if you really want to be successful. Okay. The next one is incentives. Okay. So Charlie Munger, who is the right-hand man to Warren Buffett, you probably all know Warren Buffett, probably the most famous investor of all time, or at least one of them. Charlie Munger's right-hand man said, "Show me the incentives, and I'll show you the outcome." And so, with providers, I've always been advocating financial incentives for performance on procedures. So you can stratify all of your providers on CPT codes. And I have the CPT codes. Anybody after this talk who wants the CPT codes, I can get them to you. All the urgent care and Occ Med CPT codes, these are procedure codes. So it would be kind of like CPT codes per 12 hours worked times 100 equals a good ratio. You make it times 100 because the number is going to be really like 0.001, you know what I mean? So, but you have to stratify that. You'll have a orders of magnitude differential between your providers. Some will be, say, for example, at say 25 and whatever that, and then others will be at 3. So between 25 and 3 could be millions of dollars of revenue for your group. So why not tell providers that, for example, if somebody goes out and they go from RN to nurse practitioner, or they go from a medical assistant to RN, they get a raise. Why do they get a raise? They get a raise because they have more training and more skills and can do more. Well, if the provider proves themselves to have more skills and do more procedures, why not compensate them similarly? So get this ratio on all of your providers, stratify it, take a look at it, analyze it, and decide, do we want to incentivize every provider with a percentage or a flat rate? Like if you're above 1.5 for my prior argument, I said 25 and then I said 3. So if you're above 20, you get an extra $500 a month or extra $1,000 a month. That would have a dramatic impact on their household income relative to things like college education fund savings, a bigger house, a bass boat, whatever. But I can't, I can't overestimate that enough to say you should be doing this. I used to do it. I had some PAs making $3,000 extra per month. Okay. Well, I was very happy to do that because they were doing a lot of procedures, very busy clinic, seeing 120 plus patients a day, and they were killing it. And I'm happy to share that revenue with them because the clinic itself does well with that too. And of course, that gives feedback to the community, feedback to the employers that we do things, we do procedures. Don't go to the ER, come to our clinic. Okay. Recognition and feedback. Again, if you stratify the providers on the way I just said, or a similar way, and you publish to all the providers their rank, blinding out everybody else but them. And so when they receive it, they'll see where they sit, and everybody else will see where they sit without embarrassing anybody. Okay. That's just my opinion. But they will immediately, if they see they're in the lowest 10th, or, lowest 10th of 10th percentile of the group, they're going to be embarrassed, personally embarrassed, even though they know that no one else but the leadership knows. And they're going to say, hey, how can I get higher up on that? And you'll have the easy answer. If they say, well, I need some training, good, let's do a workshop. Our medical leadership will go, pig's feet, hard-boiled eggs, subcutaneous soft tissue injections, and those kind of things. So they get the CPT code so they can raise their ranking. But you've got it, recognition and feedback. And for those that are really high, you can put out a recognition and say provider of the month, did great on procedures with a ratio of 25 was their ratio on our CPT code ratio metric. Okay, whatever that number might be. And then that feedback keeps them. You get more of what you compliment. Okay, please understand this. You get more of what you if you compliment them for high performance, you will get more high performance. But if you're always, cracking people for bad things, that just demoralizes them. So be really high energy about this. Okay. I already talked about training and support. You need to give them the training they need. Your medical leadership must absolutely do that. That's their job. They can't get around it. They can't say ridiculous things like, well, they weren't trained for it, concerned about the liability, so I'm not going to train them for it. Well, wait a minute. If you say they're not trained for it, then you should train them for it. That's what your job is to do. They can't dump that responsibility, in my opinion. And then the medical leadership needs to support them by saying, look, we're going to do these procedures. We're going to do this type of care. If you have any concerns, you call my cell phone and be available on cell phone to help them with that. Okay, next slide. Okay, so the challenges in the chess game. Okay, so when we try to up the game of providers relative to procedures. Okay, so I'm going to tell you the top 4 of the most commonly unnecessarily referred cases in workers' comp and also in urgent care that I've seen, I know about, are fingertip injuries, fractures like minor fractures, eye injuries, and lacerations. Okay, so fingertip injuries, they're smashed fingertip that can look kind of gruesome, but they heal wonderfully. I've never seen an osteomyelitis. My hand group in Chicago never had an osteomyelitis from a fingertip, which technically is an open comminuted fracture, but you suture it, you suture the nail bed, you suture the tissue, they heal wonderfully. That's in Occ 1. I've got videos on that and guidelines on it. The second is simple fractures. Why can't you treat a non-displaced rib fracture? Or I guess by definition, every fracture is displaced. So simply using the term displaced gets people concerned, but it shouldn't be, because it's all about how much displaced and where is it located and what type of fracture is it. Occ 1 has 65 fracture guidelines, all the different fractures that you can treat. And so why not treat simple avulsion fractures? Providers right now in urgent care today, it's tragic. If there's a fracture, it gets referred. And that is insane, because there's certain fractures that don't need any care at all. A simple tough fracture doesn't need a K-wire. Why would you refer that? Surgeons are there to do operations. If it's non-surgical, if it doesn't require surgery, then why would you refer it? And then if you say, well, I don't know what requires surgery, then you should learn. figure it out. Okay. There's resources that Occ One is one of them, but there's others that you can access for your providers, teach and train them which ones to keep and which ones to refer, and keep the simple ones. There's no reason you can't treat these basic, simple hairline fractures, and they're very lucrative to your financial uh, position. Okay. The next is eye injuries. We're now referring almost all eye injuries, corneal foreign bodies. Why are we referring those? Providers say, I'm uncomfortable with that. Why? Because no one ever taught them. No one trained them. No one taught them how to use a slit lamp or head mounted magnification to examine the cornea and take a flat spatula spud, which we have, and simply, anesthetize with alkane on the cornea. Then you simply take that spatula and lift that foreign body off. It's the easy. Nurses and factories do that. They have been doing that for 40 years. So why can't providers? Okay. And then lastly, lacerations are now being referred out. Why is that? It's crazy. It's crazy. Lacerations are kind of like, by definition, what urgent cares do. You suture lacerations. And so with the advent of so many less experienced nurse practitioners, PAs, and it's not their fault. It's not, they weren't trained. It's not, if they weren't trained, it's not their fault. But it's now incumbent on our industry everywhere to train them how to sew patients. Okay. And you can do that with pig's feet. Buy pig's feet, put a laceration in it, have them sit down and just suture, suture, suture. Running horizontal mattress is magical. And with like the chess game is kind of like, well, I'm uncomfortable sewing lacerations. Okay, well, let's get comfortable. And why do you take that lying down? Like if a provider says they're uncomfortable with something, the response shouldn't be, oh, you don't have to do that then. I mean, that's just that's a suicidal response. It's a financially suicidal response when a provider says they're uncomfortable, that you're not going to step up to help them to be comfortable. So the answer to providers saying, well, it takes too long to suture, I'm not comfortable with it. And then some of these, not being too critical here, but some of these private equity owned groups, they'll say things like, well, you could see 3 sore throats in the time it takes to sew 1 laceration. So let's maybe not do lacerations anymore. Or if you're really busy, refer them to the ER. It's happening right now. The answer is not refer it to the ER. The answer is learn how to sew faster. And why is that like, people look at me like I have a unicorn sticking out of my forehead when I say, well, sew faster. Like, why isn't that obvious? I have a video on Occ One. I'm suturing a 4-inch pig's feet laceration in 4 minutes on the clock. Okay. And you can time it. I did it. And it's not that hard. Running horizontal mattress. You only tie 2 knots, one at one end, one at the other end, in between. It's not hard. And so, everybody knows this. Why is it that folks practice? How do you get good at soccer? Practice. How do you get good at playing the violin? Practice. How do you get good at suturing? Practice. I mean, oh no, we in medicine, we don't practice things. We don't try to go faster. We just kind of stay where we are. We just stay right where we are, and we don't do anything that's outside of our comfort. We don't want to learn anything that's outside of our comfort zone. And that is why right now, today, we're in a profitability crisis nationwide in urgent care. Okay. So that's one of them. Okay. Another one might be, they would say, well, there's legal liability related to fracture care. Yeah, there's some. Okay. But for a hairline fracture, and you re-x-ray it in 7 to 10 days, if it's moved or shifted or something is concerning, then you can refer it then. It's not like, so that's one thing on legal liability. But what about chest pain? If anybody out there right now on this call has heard that we don't want to do fracture care, even simple fracture care, due to medical legal liability, then I'm going to challenge you. Then why are you checking patients into your clinic with chest pain? Why are you checking patients in with headache? Why are you checking patients in with a fever of 103? Why are you checking patients in with abdominal pain? All of those I just listed are 100 times more risky medical legally than non-displaced hairline fractures of many kinds. How could it be that we're not thinking this way? And so that's why I'm saying it's a chess game. We got to start thinking really well about this challenge. So legal liability is not an issue. Someone actually said, well, isn't it a conflict of interest for me to call the company about the worker comp injury, like the first phone call? That's a nice little smokescreen response. Conflict of interest, where did that come from? The general duty clause of the OSHA Act requires companies to maintain a safe working environment for all workers. How can they maintain a safe working environment when they don't know anything about the injury? It's incumbent upon us to tell them about the injury and answer their questions. Provide them documentation and paperwork, which you certainly probably do. But the first phone call by no means is a conflict of interest. That is a smokescreen. That's just poof of smoke because they didn't want to make the call. They didn't want to make that phone call. That phone call can be done with the Bluetooth in your ear. You're typing on your EHR while you're calling the company. If they don't answer, leave them a message like I just gave the 10-second first phone call on their voicemail. Okay. So again, the fear-based responses. This is fear-based, and your medical leadership needs to be able to manage the fear of the providers that are less experienced. You have to bring everybody up to the same level, practice at the same level. It's really crazy. They don't want to do soft tissue injections like epicondylitis, Dacroveins, and trigger points, and subacromial for the shoulder. All those are simple. There's no tigers there. They couldn't hit anything if they tried to hurt the patient. And if, for example, the trigger point, a parathoracic, trapezial, paralumbar trigger point, it's an IM injection, intramuscular injection. If they're worried about puncturing a lung, then use literally a half-inch needle or a quarter-inch needle. You could use a quarter-inch needle and give an IM injection to any erector spinae all the way down, or the trapezii. You will never get into any trouble. And what are we doing? We're delivering steroid suspension, 50-50 steroid and lidocaine, 50-50, like 1/2 cc, 1/2 cc, or 1 cc and 1 cc. You're injecting it intramuscularly. You're delivering the medication to the pain generator that you found with your fingertips on your careful palpation examination, identified the focal area of tenderness, okay? And you're injecting it. You're bypassing the stomach, okay? Why is it that we're pill-centric? We're very pill-centric. So, no, I'm going to give you a pill. I'm not injecting you. Okay, why? Why not? Okay? Soft tissue, physiatrists, family doctors, occupational docs, orthopedics, ortho-PAs, everybody out there, they're doing injections like crazy because their attendings are saying, you do the injections. Why should I do that? I need to operate. And so their PAs and nurse practitioners are doing the injections. Why can't we do that in urgent care? It's IM injection. Do nurses give IM injections? Absolutely, by the thousands. What's a flu shot? It's an IM injection. Why not? What are we afraid of? So it's incumbent on medical leadership, again, to bring providers up to a consistent level, a higher level, to practice a high level of their license. They're certainly licensed to give subacromial injections, trigger point injections. Subacromial, I mean, that space is 2 centimeters in size, and you there's nothing there that you could hit that would be a problem. You can't. There's never, in my practice in 40 years, there was never anything went wrong with an injection, not one. And as far as I know, nothing went wrong with simple fractures either, or eye injuries. I actually did a study and published that in JUSUM on eye injuries. I've never, ever seen a corneal infection from a work-related injury, not one. Corneal infection from contact lenses, that's different. That's not workers' comp. But workers' comp injury, wood, metal, insects get on the cornea, and you remove it, and they don't get infected. And you don't need antibiotics on the first visit. You check them back all the next day. 95% of them are 100% better. You release them. It's no big deal. Why are we afraid of our own shadows? Why do we have to give antibiotics to corneal abrasions? That's OSHA recordable. It's not necessary. But anyway, let's open it up to some questions.
Cool. Yeah. I think you can all see that Dr. Kaler is the perfect person to give this talk. But like you said, if you want to, there's a Q&A section or a chat, either one would be fine. If you do have any questions, we'll stay on the line here for a couple minutes as those potentially come in. So you can see our contact information, both Dr. Kaler and myself, or you can check out our websites. The URLs are just what are in our email, but otherwise, yeah, we'll stay on here for some questions.
Overrating, waiting. I want to reiterate the big four provider performance issues. Okay. So enhancing or maximizing provider performance in Occ Med means providers do not take people off work unnecessarily. You only take them off work if they absolutely have to be off work on a clinically based reason. So light duty, they get light duty, and it could be desk duty only is better than off duty. Second one is unnecessary recordables. Don't give prescription meds on the first two visits. Okay. Why do you need to give prescription meds early on in a sprain, strain, or contusion? So simple injuries, sprains, strains, and contusions. They don't need prescription meds. If you give them Tylenol OTC, which Tylenol is always OTC no matter the dose, and then OTC ibuprofen or naproxen, which would be 220 QID or 400 QID, is non-recordable for those two medications. We used to fill them in our clinic and give the patients 2 bottles when they leave. We do need to do something more than nothing for these patients. Give back strains of back support. That's not prescription. It's not recordable. So you give them 2 OTC meds, back support for a lumbar strain, then they're fine. You recheck them back in 5 to 7 days. 90% of them are getting better. You move it along. It's non-recordable. The patients, the companies love that. Then work restrictions. Find out the job they actually do and don't give restrictions that don't relate to the job they actually do. For example, if somebody gets hurt in the office on a sedentary job, likely for whatever that injury is, they can be at full duty on their sedentary job. They might have slipped on something in the office. They've got a strain, but they sit in a chair all day. That's their job. It's sedentary. So why not put them on full duty? Then the fourth one is first phone calls. This is just no brainer. We did this starting in 1988. Why wouldn't you call the company and give them a little short rendition on what's going on? So that's if you can get your providers to do those four things, I am promising you they will be viewed as rock stars by the employer community. Your practice will grow, satisfaction will skyrocket, and your sales will get more easier for
Cool. We got
sure.
a couple questions that came in. First one here is, I think, actually, Martin, if you work for a company and not a clinic, but they're asking, how do we pick the right health clinic for our company? Seems like that's not the model anymore. Does that make a sense?
Yeah, absolutely. Yeah, it's not the model anymore. Absolutely, Martin, 100%. That's what I'm saying. That's why the opportunity's never been greater. So how does a company pick a clinic? You have to interview them, literally say, come on over, let's talk. And they come to your place, you sit in the conference room, ask them questions. Ask them about your providers take people off work. Your providers give prescription meds on the first visit. Your providers call us on all first visits. Your providers provide work restrictions that make actual common sense. And if there's any equivocation when you ask those four questions, they're not the clinic for you. Okay. And you might say, well, there aren't any around here. Well, then that's a problem. Then you might need to look to bringing things in house, depending on how big your company is. Can you hire a part time nurse practitioner or PA to come in that does get it, that does have good Occ Med background and wants to work there at your factory? Or you could maybe even find the best of what you do have available that's still not optimal, and then teach them and say, here's how we want it done for our account. So write in specific instructions in your profile at the clinic to say, we want a phone call prior to prescribing prescription meds or taking anyone off work. That would be one way. Then you have that conversation with the provider. Well, why exactly is it necessary to be off work? Because we can have sedentary work. We can have them do inventory. We can have them count widgets. Okay. So I would say that you engage at that level. And obviously, the bigger the company you are, the bigger the employer are, the more pull you're going to have. But, I learned this back in 88 when I started, that it's reasonable to accommodate the requests of these companies and still practice great medicine. This is not a conflict of interest. I have never, ever, not once compromised the care of an injured worker for some company request. Never. Why? Because I sleep good at night. I've never been sued. I mean, come on. I mean, you can do this.
Great. A couple more questions coming in. Can you speak to the recordability of the soft tissue therapeutic injection? Also, what about the ED follow-up? I want to alter their restrictions and management. Can that reverse recordability?
Okay, two questions. Soft tissue injections are recordable. Why? Because it's a prescription medication. So any prescription medication, if it has to be a prescription, that's recordable. So we'll do our soft tissue injections on visit 3. It's in OcDoc 1, our guidelines. That, by the way, if anybody wants to see OcDoc 1, the website, it's a game changer. It's really helpful, let me tell you. Then just ping me in my email address, and I'll happy to show you a demo of it. But soft tissue injections are recordable because they're a prescription med. But we wait till visit 3. If the patient's not improving at visit 3 with the OTCs, back support, or whatever else we're doing, hot to cold, therapeutics and such, then we'll go to a trigger point. Is it clinical consideration? Second question was ER follow-up. Okay, so ERs blow recordables. That's what they do 100% of the time. They don't know any better. It's okay. It just is what it is. They give prescription meds. That's their paradigm. So if within a reasonable period of time, someone well-versed in occupational medicine makes the statement that that medication the ER prescribed or that restriction the ER gave was clinically unnecessary or clinically inappropriate, and send that to the company, the company may or may not record it. So this doesn't create any liability for you whatsoever. The OSHA 300 log is 100% the company's responsibility. They are 100% liable for it. You have no responsibility or liability for that ever, ever, never, ever. Okay. So you can say, yes, company, that the medication prescribed was clinically unnecessary or clinically inappropriate, whichever word applies better. And the restrictions were also clinically unnecessary, whatever it might be. Then they can take that letter, put it in their file, and not record it. That's their choice, though. They could get, pushback from OSHA if they ever audited their log, but maybe they won't. So, and that's true wherever they might go and get some, like their own family dog. They went to their family dog, got a prescription. Is this appropriate? And then it'd be good for you to see the patient too, in conjunction with you rendering this opinion about the unnecessary treatment. It's better if you have examined them, but it's not necessary essential. It's not essential, but better if you do actually lay your hands on the patient.
All right, one more here. Amanda is asking for your general thoughts and feedback on the scenario. They're getting asked to provide transportation on initial visits to and from. The carrier does not reimburse for the clinic. They only reimburse patient for the mileage.
Okay, so I know of in certain competitive markets that clinics have used transportation as a sales tool. So you could do that. I'm not saying you can't do that. I looked into that once, and the insurance was like ambulance insurance cost, like $75,000 a year. Insanity. So I ditched that long ago of doing transportation because of the insurance cost, and you have to have insurance. You can't just send a staff member out there to go do this, because if there's a motor vehicle accident, you can't imagine the liability that you have. Your employee, their employee, and everybody else in the crash, and you can't be underinsured. I would recommend against it and say that we're really not equipped to do that. The workaround, though, is to pay for the cab ride or the Uber ride. Okay, that's because Uber has liability insurance. Okay, so Lyft or whatever. So you could pay for that. You could say, okay, we'll set up an account with Uber and Lyft, and here's the phone number you call. Tell them it's on our account, and then they'll bill us for it or something like that. So you could set up. There's even local cab services. Heck, there's guys out there that do like limo services, and they'll be glad to grab this kind of business. So that would be, if you're going to do it, that would be the way to do it, with a cab service of some kind.
It sounds like, so Amanda did add in the chat here that they are using Uber to do some of this today. She's just curious if you knew anything about the liability, if it is their account, if there's any additional liability there that you know of.
No, it wouldn't be, because you're paying Uber to do the transportation. It's on Uber to have the liability insurance. And obviously anyone getting transported in a cab is not hemorrhaging. Okay. So it's not like they're going to suffer, it should have been an ambulance, no, it's not going to be like that. Okay. Nobody, conceivably they'll send someone with chest pain. That could be an issue, but it's still on Uber and the company. It's on them. They put them in a cab, if it's chest pain, it turns out to be myocardial infarction. That's on someone else. That's not on you. You take them when they get there, and then you figure it out when they get there.
Great. She really appreciates your answer there. Any other questions? We'll give it a couple more minutes. Just say, Dr. Kaler and I have been in the space for quite a while. So if you have anything related to Occ Health or work comp in general, feel free to put those in the chat, even if they're off topic a little bit. But otherwise, we'll give it 1 or 2 more minutes and let you on your way.
I can say this about co-work. I know of clinics that are having good success with co-work on the back end management of that platform helps streamline all their Occ Med back end. So Dusty's a good guy for that to consider that too, because my goal here and Dusty's is for you to be successful. Okay. I would beg people if I could, if it would make any sense to beg you to get your providers to do the big four. It's that simple. Those are administrative issues. They're not even a procedure. Okay. Lost time, OSHA recordables, work restrictions, and first comp phone calls. That's administrative. And it's a trade secret. It's just amazing what that will do. It's so magical. You will take over your market share. You will take over, because I did it. I took over every market I was in, every one of them, including Chicago. We had 37 clinics in Chicago, and we dominated in work comp. Not anymore, because we were sold, and now they're dropping the ball, unfortunately.
Okay, a couple more questions came up here. So related to concussions, it's a contusion until there's concussive symptoms. To mitigate, we historically have prescribed a brain rest, which is lost time. Any pearls specific to concussion that our new provider listeners would benefit from?
Okay, concussion. All right. So what you really have to know about this, it's all about the energy imparted to the brain. Okay. So I just have to tell you a case here. I'm glad we have time to do this. So I literally had a case once. Dr. Cato, will you help us manage this case? They went off to a headache clinic, and I said, well, because this is remote to me. It was a remote consultation with a large corporation, so I couldn't see the patient. But the patient, here's the history. They opened a door that had an aluminum tube as the handle and two screws through it into the glass door. The worker pulled on the aluminum tube. It came apart and hit him in the forehead. Okay. So that aluminum tube would weigh maybe 6 ounces, 8 ounces. And they were trying to open the door and it came out. So the energy imparted to the human's scalp was minimal, and to the brain was zero. $50,000 later at the headache clinic, I'm getting involved. I called him up. I talked to the nurse practitioner presiding over the case. I explained that there was no biomechanical or physics relation. There's no physics that could support that there was any G-forces applied to the brain on this incident. And they released the patient shortly thereafter. So this is how crazy. So concussion is absolutely overused as a term. That term should never be used unless it meets the criteria, which means high energy. Okay, so that would be a baseball bat. Now you're talking. A wrench, a large wrench that slips off and hits him in the head. And the evidence of trauma, like was a hard hat, was it scratched? Was there a contusion? Was there a hematoma? So you examine the scalp and look for evidence of traumatic impact. So, for example, like a really thin rod imparts less trauma to the brain versus a 2x4 or a 4x4. So you have to really engage on the mechanism of injury, the physics equals MC squared. Okay. Mass times acceleration. So what was the mass? If the mass is nothing, then you can't have energy, okay, imparted to the brain. Okay. So that's that. Okay. So let's say they have a qualifying energy experience and they are noted to be dazed at the scene, confused at the scene. Like really, they were confused. They certified the patient was confused at the scene, plus or minus loss of consciousness. Loss of consciousness is a concussion. We're good there. But no loss of consciousness plus a neurologic, dazed, confused, disoriented, that's good too. Okay. So those, I'm good with that being a concussion. Slurred speech, they come in to see you, you do a neurologic exam, they're not 100% right. Then you get a CT. Okay. You get a CT that you have to go to. I have three categories, category 1, 2, and 3, and I'll talk one on where you go, whether you go to ER for the CT, outpatient CT, or no CT. So I have that in my guidelines and I explain everything. But so that's kind of the overview. It's all about the energy and part of the brain. And then, so you mentioned post concussion syndrome. That's rare, possible, but there's no reason you can't follow these patients on for a while until their symptoms improve. And if they're significant enough and aren't improving, then you need to find a headache clinic that's well versed in post concussive cases and not just a quote unquote headache mill. Okay, you don't want to say headache mill. A neurologist is fine too. A neurologist that's comfortable with evaluating post concussion cases, and they should be. Then you would refer that, but that's down the road. That's probably 3 weeks. There's no reason to refer someone for post concussive symptomatology with a negative CT until like 3 weeks or so. But did I cover the question there, Dusty?
I guess I was the one thought, like, how do you feel about them, prescribing brain rest before they know conclusively if it is concussion? That obviously is lost.
No, no, you figure that out at the time of service. Okay, brain rest. Okay, brain rest is for full blown concussion. You better have solid clinical evidence of a full blown concussion to send them home for brain rest, so to speak. I'm not against brain rest, but don't overdo it. Don't let that be an escape hatch for, oh yeah, I want to take them off work anyway. Okay, easy peasy, off work, brain rest. No, no, no. No, they can do sedentary work in the office. That could be their restriction. Because I mean, a lot of them, like if they're going to the ER for their CT, they're going to be off work that day anyway. But you should schedule all your head injury cases back to see you the next morning, period, full stop, as a matter of policy. Whether they went to the ER, outpatient CT, or no CT, every 100% of your head injury case should come back to see you the next morning, same as eye injuries. All get rechecked the next day as a matter of policy. It's absolute no-brainer. The best care is close follow-up. The best care always will be close follow-up for head injuries. Things could change the next day. But brain rest, that's rare. That's going to be really rare, but it's concealed. They're still kind of like woozy. They still have a headache, even though CT was negative, and they're a little bit tipsy on their balance or whatever it might be. Then they can be off work because they do need brain rest at that point for that.
Cool. Amanda, I can send you an email offline, give you an update. I'm not seeing any other questions. Again, I'll give it like one more minute. We'll just wait here, but otherwise, we obviously appreciate you all jumping on. Hopefully you found it valuable, beneficial. We'll also send out the recording to everybody that registered and attended, so you can watch that in your spare time and forward on to your other team members. Again, I am not seeing. I'll give you 10 more seconds. Martin, give me more compliments. You gotta send him a gift or something. All right, I think that is doing it. Again, thank you all for attending. We will obviously do another one here at some point in the next couple months. Otherwise, hope you all have a good rest of your day.
Take care, everybody.